This lecture is going to cover the cardiac conduction system, which is a specialized system in the heart for generating electrical impulses in a very regular, repetitive fashion. And it's also designed to conduct the impulses rapidly through different areas of the heart to allow the heart to work very effectively, or should say efficiently. So what we're going to do is we're going to look at the events involved in generating the electrical impulses, as well as the various components and functions of the cardiac conduction system. I'll kind of give as an overview is in order for you to generate effective pressures to get blood to move from point A to point B in the heart and then out of the heart, is you need a very coordinated mechanism or coordinated way of getting the muscle to contract. And so having this cardiac conduction system is very important. But also, as a reminder, is the heart can beat without external stimulation. The heart will contract on its own because it has these pacemaker cells in the heart, and we should say cardiac muscle is myogenic. So we're going to start up in, talk about first going to do a little histology, then we'll talk about the different components of the cardiac conduction system. We'll start with the SA node on down to the remaining parts of the conducting system. So first, majority of your heart is composed up of muscle, cardiac muscle cells. Those are your mechanical cells. They contract to create pressures to open up valves and get blood moving. But we have these electrical cells that they don't contract. They're non-contractile, but their job is to either initiate electrical activity and actually you have to initiate electrical activity, then you need to conduct those electrical impulses through the heart. Now, cardiac muscle, remember, has these structures, which you see here and here and here and here, which you see here, are our intercalated discs. The intercalated discs are structures that allow ions to move very quickly from cell to cell so that the muscle impulses travel very quickly and we can have this very coordinated contractions as a result of it. The cardiac muscle we refer to as either being myogenic or that tissue is being autorhythmic or self-exciting because of the pacemaker cells that we're going to talk about. But then we also have these intercalated discs. Now the contractions of cardiac muscle follows the order in which the electrical impulses are conducted through the heart. They actually begin in the atria. So you start with the atria that depolarize, and then the muscle contracts, and then it's followed by ventricular contraction. And in the ventricles, the first part of the ventricle contract is this part here, which is, and I'm going to just abbreviate, is IV, interventricular septum. Will depolarize and then contract. And then we'll have muscle spirals that starting from here at the apex of the heart, going up this way. So then it's muscle spirals from the apex up to the base. And the very last part of the ventricles to contract are the muscle fibers at the base of the heart. So it follows the order in which the muscle depolarizes. So let's start with the first part of the cardiac conduction system, is our SA node. SA node is also called the sinoatrial node. It's also referred to as the sinus node. Any of them will work. Now the SA node is located up in the right atrium. Now the SA node, the cells are called P cells, which you see over here. The P cells were originally at some point in time some muscle cells, but they end up having very few contractile fibers to it, very few myofibrils. They don't contract anymore. They have this intrinsic ability to depolarize on their own. They have automaticity. They self-excite. The reason why they self-excite is that the cells are notoriously leakier to sodium, okay? So they're leakier to sodium ions. Now, if you look here, what happens, if you kind of see what happens in the SA node, these are referred to as slow action potentials, is there is never really any true resting potential. Is it just slowly depolarizes here because the cells are leakier to sodium. As sodium moves into the cell, the resting membrane potential becomes less negative. And once you reach this point here, threshold, then we'll start generating an action potential. Now what you'll notice here, which is kind of unique, is the upstroke in the, or we call phase 0 of the action potential here, is due to the influx of calcium ions, not sodium. What happens is, because of those cells being leakier to sodium, the fast sodium channels are already refractory. They're blocked by voltage. So the fast sodium channels are blocked, but the slow calcium, they're called slow calcium sodium channels, but just think of it as calcium, primarily calcium. It's the slow influx of calcium is going to be responsible for this depolarization in the action potential here. So you have this slow influx of sodium. We're closer to threshold as it is. Once you reach threshold, the action potential is a result of the influx of calcium ions. So remember, as more positive charges are coming in, you see the membrane potential becoming less negative and eventually becoming positive. Now up here, what's going to happen is the calcium channels are going to start to close up, and then what we have here is the efflux, or they say outflux, of potassium is going to result in repolarization. So you have repolarization here. So this part here is similar to what you learned about in action potentials in AMP1, but what here is a little bit different. So we have, it's an influx of calcium responsible for the depolarization phase in the action potential of the SA nodal cells. Now the SA nodal cells, is very important to remember, the reason they self-excite is they're leakier to sodium. And you see it's kind of slow, so they call these slow. So this will generate an action potential, but that's going to do is then be transmitted through the rest of the heart. So if we go, actually let's do this first, is the spontaneous depolarization rate of these cells correspond to, actually I'm going to put this here, 60 to 100 times per minute, which does correlate to our normal range of heart rate of being 60 to 100 times per minute, or beats per minute. But that's the normal depolarization rate of the SA nodal cells, so that corresponds to our normal resting heart rate of 60 to 100 times per minute. Now, the autonomic nervous system can influence the depolarization rate of those SA nodal cells. So the sympathetics can increase depolarization rate, the parasympathetics can slow it down. But the intrinsic, the normal firing, is anywhere from 60 to 100 times per minute. Now if we go back here to this picture, when those SA nodal cells fire, what's going to happen is you have these transitional cells next to it. Well, that will depolarize those cells, and then we also have attached these cells as muscle. We have atrial muscle, that the atrial muscle will start to depolarize, but we also need to do is we need to get we don't want just the right atria to depolarize by itself. We want the left atria to depolarize around the same time because we want them working together as a unit. So we need a means of getting that electrical impulse that started up here in the SA node over to the left atria, to other parts of the right atria, but also eventually down towards where we can get the ventricles to start to depolarize. So what's going to happen, and I'm going to erase this so you can see here, is the SA node fires. It's going to start to send the electrical activity through the parts of the conduction system, such as this one here is, we call an interatrial band. This one here is an interatrial band because it's going between the atria. That's going to allow it to get over the left atria. We have these various internodal tracts because they go from node to node, because we have an SA node and down here is an AV node. So this is going to allow this to get down towards this part, which is still in the right atria, but at some point we're eventually going to get down into the ventricles. So we have SA node fires, sends the impulse, spreads it out through the atria, so very quickly through these parts of the conduction system, but also then we're going to have to start to excite the muscle, and when the muscle depolarizes, generating extra potential, then hopefully we'll get a contraction. So we go from the SA node down to here, the AV node. This is where some important stuff is going to happen. So if you notice over here in this picture, what I've done is I've put some numbers. This is going to correspond to tell you that how much time has elapsed from the point where you initiated the impulse here in the SA node and you got to that particular point in the heart. So if I go from here to here, only 30 milliseconds has elapsed to go from the SA node to the AV node. That's pretty quick. But as I go from SA node down into starting getting into the ventricles, that corresponds to 0.13 seconds or 130 milliseconds. That's a significant delay, but there's a reason for that. Is the AV node is also called, we have the AV node, also called the atrioventricular node. This is found in the right atria. The cells there have very few gap junctions. The fibers are fairly small, so the conduction velocity significantly slows down as it moves through the AV node, but there's a reason for this. That delay is going to allow the atria to finish contracting, pushing blood into the ventricles before the ventricles begin to contract. So that delay in the impulse from the atria to the ventricles is really important. So it allows for the emptying of the atria before the ventricles contract, because you do not want the ventricles to contract while the atria is trying to contract, because atria is moving blood this way, ventricles going to be moving blood that way, and it wouldn't go anywhere. So it allows the ventricles to completely fill. So the AV node has that delay, pretty important delay. Well, also, as we go from the atria into the ventricles, we have only one normal way for that electrical impulse to get its way from the atria into the ventricles. Let's make a different color so it's easier. Start doing it in gold. Right in here. This is called the bundle of His, or the common bundle, or the AV bundle. Any of those names are perfectly acceptable. That is the only normal route in which the electrical impulse should go from the atria into the ventricles. What we have between the atria and the ventricles is that annulus fibrosus of the heart. It's a connective tissue that acts as an electrical insulator. So any electrical activity from the atria is not going to prematurely start exciting the ventricles up here, because I want the ventricles to contract in a particular fashion. I do not want them to contract from top to bottom. So I have the annulus fibrosus there. So what I need is I have the common bundle, or the bundle of His, that's going to allow that impulse to go down to the ventricles. And you notice if we're going to follow a certain pattern, you're going to follow the green. Is what we're going to have is, starting up in this region, we're going to start with fibers that are part of the Purkinje system. Purkinje fibers are very, very large fibers, lots of gap junctions. They conduct the electrical activity extremely quickly. And what's going to happen is we're going to start is we have over on this side, this is the right bundle branch. Over here, that's the left bundle branch. The right bundle branch is going to allow that electrical activity to go into the right ventricle. The left bundle branch transmits the impulse into the left ventricle. They're located along that ventricular septum. So you'll notice the first part of the ventricles to contract will be the septum. It's going to kind of act as a brace. And then what happens is that impulse will follow the right bundle branch. That comes down the fibers that are going to come down here towards the apex and then move up. And so you have, these are terminal Purkinje fibers. So what happens is the septum will depolarize, and then the muscle fibers that are closest to the apex start to depolarize, and then it moves up. So it follows when you depolarize that part of the muscle, then it's going to go from muscle to muscle. Then you're going to depolarize in the fashion that we want, or I should say, in the muscle to contract in the order that we want. So you're going to contract from here and then move up the way we want to do it. So it allows it to move very, very quickly. If you did not have the cardiac conduction system, the way it's set up, the heart would not be able to work in a coordinated fashion, would not be very efficient. I want both ventricles to contract about the same time. I want them to work as a unit. I want the atria to contract about the same time. I do not want the atria and the ventricles to contract at the same time. So you want the atria contract, you want that little bit of delay, and then you want the ventricles contract. So you'll notice, if you look at the numbers again over here, the atria contracts, all the atria will be depolarized within about 90 milliseconds. Over here in the ventricles will contract, so you can just do a little bit of math. They'll contract from the time from 0.16 to 0.22. That's going to contract within, let's see, 60 milliseconds. So technically the ventricles depolarize faster than the atria. And they're bigger, way bigger than the atria. The reason why they depolarize much quicker is because of those Purkinje fibers. And that's what we want. We want them to depolarize very quickly. And I want the left and right ventricle to pretty much depolarize and contract about the same time, which is what happens. Now, if there's problems with conduction, that does create problems. Some people have blocks within the conduction pathway, and that will result in the heart not being able to work as efficiently as it should. So what happens, one of the things is, what would happen if the SA node doesn't fire? I don't have that spontaneous depolarization. What's going to happen? If the heart doesn't depolarize, it won't contract and you're going to die. Well, we have backups. Other parts of that system have the ability to spontaneously depolarize. If FA node fails to fire, we do have P cells in the AV node that will spontaneously depolarize, but they depolarize at a much slower rate than the SA node. And what they refer to as, if that happens, we're going to refer to as an escape rhythm, because these escaped from the dominance of the SA node, because the SA node normally fires anywhere from 60 to 100 times per minute. Before the AV node, the P cells in the AV node would begin to fire, SA node has already fired and kind of started it going. So normally SA node is not going to spontaneously fire, and then the AV node spontaneously fire. AV node is only going to spontaneously fire if the SA node fails to fire or any block between the SA node and the AV node happens. AV node will fire, but the rate is slower. It's about 40 to 60 times per minute. Now, if something happens and AV node doesn't fire, or I can't get that impulse into the ventricles, they better depolarize and contract so you can pump blood up to the lungs or up to the rest of the body. Is what will happen is we have Purkinje fibers, and the Purkinje fibers have the ability to self-excite, but they're kind of really slow and they're not very reliable. They're not necessarily going to do it all the time, but they go anywhere from 20 to 40 times per minute. Now, if your depolarization rate of your heart was 20 times per minute, that would correspond to a ventricular contraction rate of 20 times per minute. I'm sorry, you're not going to be able to pump blood enough to keep you conscious. So that's going to make the heart rate very slow and not very good. But there are conditions that result in contraction rates of the heart being slower as a result of conduction blocks. Or we also can have kind of where the atria contract on their own and the ventricles contract and they're not coordinated. That also happens for various conduction blocks. Now, another thing that can happen is sometimes areas of the heart just spontaneously depolarize, and refer to them as ectopic foci. Foci would be focus if it was one area of the heart, foci if it's multiple areas. So you have like a cardiac muscle tissue that gets irritated and it spontaneously depolarizes. That will cause the area around there to depolarize, contract, and then you're going to have a non-coordinated contraction of the heart. And people who have some things that people, when they have ectopic foci, is they may have something called either premature atrial contractions or premature ventricular contractions. I personally have premature atrial contractions, but I've known plenty of people, students that I've seen in lab, where they have premature ventricular contractions. It doesn't always happen all the time, but again, if different areas of your heart contract prematurely, you may not have filled up as efficiently as you should and cause problems with your cardiac output. Now, this is where I'm going to end on the cardiac conduction system. We'll talk about the action potentials in cardiac muscle that result from the depolarization of the cardiac muscle in class. So we're just going to stop here at this point in time.